Sorry, just a minute. I'll be presenting menopause under the following headings: questions, definitions, stages, further definitions, epidemiology, etiology, clinical features, diagnosis, treatment, role of family physician, conclusion, and references. So before we get down to business, let's just start with the following few questions. If menopause occurs in a woman younger than years, it is considered to be premature. A 40, B 45, C 50, D 30. During perimenopause, some doctors may prescribe with treatments. A, hormone therapies, B, birth control pills, C, benzodiazepines, D, A or B. Which is not a usual symptom of menopause? A, night sweats, B, back pain, C, headaches, D, anxiety. The average age of menopause is A, 51, B, 60, C, 55, D, 49. The most characteristic symptom of menopause is A, hot flashes, B, varies from woman to woman, C, mood swings, D, vaginal dryness and painful intercourse. Menopause increases health risks such as heart disease, sexually transmitted disease, osteoporosis, A and C. Women who are going through menopause should take hormone therapy, estrogen therapy, bioidentical hormone therapy. It depends on the woman's symptoms and medical history. So with that in mind, we are going to the presentation. First, let's start with a definition of menopause. Menopause has been defined as the permanent cessation of menses as a consequence of ovarian follicle depletion. In other words, imagine the ovary as containing a lot of follicles which later develop into eggs. And once they are depleted, as a result, it initiates a series of physiologic and physical changes which result in the phenomenon called menopause. Its hallmark is a permanent loss of ovarian function due to depletion of ovarian reserve, i.e. ovarian complement of oocyte granulosa cells. Now, these are the stages and reproductive events as concerns menopause. 1, premenopausal, regular menstrual cycles in the 22 to 35-day range. 2, late premenopausal, a change in cycle length of greater than or equal to 7 days in either direction from the patient's baseline. 3, early transition, changes in cycle length of greater than or equal to 7 days either direction from the patient's baseline or 60 days of amenorrhea. 4, late transition, 90 days to 11 months of amenorrhea. And 5, postmenopausal, greater than or equal to 12 months amenorrhea excluding hysterectomy. And these are the 4 stages of menopause in a diagrammatic, expressed in a sort of a diagrammatic way, with a focus on the symptom experience, which we'll be talking more about the symptoms later on. We have the premenopause, which starts when a woman enters her reproductive years, as we've said. Perimenopause, where estrogen levels begin to decline and fluctuate. Premature menopause, which may be due to illness, genetics, or medical procedures. Then the menopause, and then which is the end stage of a natural transition in a woman's reproductive life, where the ovaries stop producing eggs and the woman can no longer get pregnant naturally, which is marked by the total cessation of the menstrual cycle for 12 months. Postmenopause refers to the stage after menopause occurs and lasts the remainder of the woman's life. This is a staging which was devised by the Stages of Reproductive Aging Workshop, or the STRAW Workshop, in July 2001. As you can see, it divides does the stages according to duration of stage, and more importantly, focuses on the menstrual cycles and the endocrine stage. As you can see, the menopausal transition is characterized by variable cycle length, greater than 7 days, different from normal, 2 skip cycles of amenorrhea, and then post-menopause, 1 year, amenorrhea for 12 months, then 4 years after amenorrhea, and then late continues until demise. And you can see the endocrine signs too as well, which is characterized by an increase in follicle-stimulating hormone with no response. Now let's go to some further definitions. Menopause. There are various definitions regarding the phenomenon called menopause. We'll start with natural or spontaneous menopause, which is recognized to have occurred after 12 months of amenorrhea, for which there are no obvious pathological or physiological causes, which occurs, as we have said, due to the depletion of ovarian follicles, resulting in near complete but natural diminution of ovarian hormone secretion. There is no independent biological marker for menopause. Perimenopause, premenopause rather, is often used to refer to the entire reproductive period. That's from the age of menarche up to the final menstrual period. Perimenopause is the period immediately before and up to 1 year after the final menstrual period. It lasts for 3 to 5 years. There are increased blood levels of follicle stimulating hormone, anovulatory cycles, reduced fertility, erratic menstrual periods, and onset of symptoms. This term is used interchangeably with menopause transition. Menopause transition or perimenopause begins on an average 4 years before the final menstrual period and is characterized by irregular menstrual cycles, endocrine changes, and symptoms such as hot flashes that may affect a woman's quality of life, and it is a biological marker for chronic disease. Because of the fact that it's related to the underlying aging process, the biology and symptomatology may be blurred. It may be confused as something that is, the symptoms may be confused with something that is more of a result of the normal aging process rather than menopause itself. Long-term effects of the bone and heart have been related to estrogen deficiency. Climacteric, literally it means the long rungs of a ladder. And when it's the interchangeable with perimenopause and menopause transition. And when associated with symptoms, it is termed as the climacteric syndrome. That refers to the perimenopause and the menopause period. And of course, is a layman's term, not to be used in scientific papers. And then post-menopause is a span of time dating from the final menstrual period, regardless of whether the menopause was spontaneous or iatrogenic. Induced menopause is the cessation of menstruation that follows bilateral oophorectomy or iatrogenic ablation of ovarian function. Temporary menopause, well, is due to temporary interruption of the ovarian function due to one symptom or the other, e.g. polycystic ovarian syndrome. Early menopause is a time span between the spontaneous and iatrogenic menopause occurring between the age of 40 years and the accepted typical age of menopause for a given population. Currently, the consensus is to treat such patients with hormone replacement therapy till the age of menopause. That will be discussed, hormone replacement therapy will be discussed briefly later on. Delayed menopause is not defined, but may be important in terms of increased problems associated with the hyperestrogenism, that's high secretion of estrogen. And it's defined as being 2 standard deviations above from natural age of menopause in a given population, which may be considered beyond 54 years. Population-based studies are needed to derive these cutoff values. More studies are needed to be done. And then postmenopausal bleeding is the bleeding that occurs over 12 months after the last normal period. It is heavily recommended that any vaginal bleeding occurring 6 months after the last period should be investigated immediately. Epidemiology. Of course, menopause will eventually occur in every woman for as long as he or she lives. As long as she lives, rather. Age-wise, the median age of menopause in Europe ranges from 50 to 52.8 years. In North America, from 50.5 to 51.4 years. In Latin America, from 43.8 to 53 years. And in Asia, from 42.1 to 49.5. I was unable to find figures for Africa. In Nigeria, I was lucky enough to find figures. And in Nigeria, menopause occurs between the ages of 45 to 52 years. But in rare cases, there may be also cases of menopause occurring between the ages of 36 to 40 years. And of course, that's early menopause. Epidemiologic studies done in a in a review of literature done by a group of scientists, showed the following: that the prevalence of menopausal symptoms in African women is disconcertingly high. Women from South America have more of depression, sexual dysfunctions, and discomfort associated with muscle pain and joint aches. Symptoms most reported by women in the US are pains associated with muscles and joints. Women in Australia suffer from vasomotor symptoms and sexual dysfunctions, whereas women in Asia have an increase in depressive disorders. In Europe also, there's been reports of depression and sleep disorders. Now, menopause. In finding about the etiology of menopause, I found out this rather interesting evolutionary hypothesis from an evolutionary point of view. There are several hypotheses as to why humans go into menopause, from the evolutionary point of view, they can be divided into three hypotheses. There's the grandmother hypothesis, which speculates that older non-reproductive mothers help their childbearing daughters and thus increase that's the childbearing daughter's reproductive fitness, I should add, at the expense of her own. The mother hypothesis assumes that older women stop reproducing because it is too risky for them to give birth, and thus to increase the chances of survival of their offspring. In other words, the mother has to look after her offspring as they grow. So in order to increase the chances of survival of the offspring, she has to stop giving birth so that she can give attention to the living. Then there's finally the reproductive conflict hypothesis, also known as the mother-in-law conflict hypothesis, which suggests that menopause is as a result or a side effect of the cost of intergenerational reproductive conflicts between the older females and younger females of the same social unit, which impacts the reproductive fitness calculations. These are interesting hypotheses which require more studies. So the direct causes of menopause, it could be natural, which happens in most people, surgical, which could be due to removal of the ovary or any of the reproductive organs, premature ovarian insufficiency, and then of course post-chemotherapy radiation, either for the cancers involving reproductive tract or cancers elsewhere in the body. Whatsoever the cause, the above causes set in motion menopause by terminating normal ovarian follicular function. Risk factors for premature menopause. We've mentioned the fact that some women can have menopause prematurely. It may be a common genetic issue. Other women in the family who have probably had it. It's also due to surgery to remove the ovaries, as we mentioned earlier, radiation and chemotherapy, taking drugs that lower estrogen levels, smoking and other bad lifestyle choices, and finally, problems with the immune diseases, for example. Menopause, as we know, results from loss of ovarian sensitivity to gonadotropin stimulation, which is directly related to follicular attrition. To briefly mention the fact that at birth, the female infant at birth usually has about, if I recall, 2 million ovarian follicles in each of the ovaries. The number of follicles begins to diminish over time until around the time the woman reaches reproductive ages, the number in the hundreds of thousands, from 2 million downwards, and it keeps reducing until menopause, when they can get to a very low or zero level. Anovulatory cycles and absence of cyclicity, of course, become common, with a highly variable pattern of gonadotropin and steroid hormone production, estrogen insensitivity, failure of the luteinizing hormone surge, then finally the occurrence of the final menstrual period and permanent amenorrhea as a result. There's a marked reduction in the sensitivity of the central nervous system to both the positive and negative feedback effects of estrogen. And as a result, there's increased follicle stimulating hormone to restore that feedback mechanism. But unfortunately, it doesn't work this time because of the follicular attrition. These changes in sensitivity explain menstrual irregularities and systemic systems which are present in the time before the final menstrual period. So to summarize, menopause is as a result of a combination of the sensitization of the hypothalamic pituitary ovarian feedback loop, a decrease in the follicle number in the ovaries, and insensitivity of the remaining follicles to the positive feedback of estrogen to trigger ovulation. These are the clinical features. The clinical features of menopause are as follows: vasomotor symptoms, hot flushes, night sweats, sleep disturbances, that's insomnia or poor sleep, mood changes, irritability and depression, urogenital effects, vaginal dryness, urinary incontinence, sexual well-being, decreased libido, menstrual cycle, amenorrhea, nervous system, headache, cognition issues, worsening of memory, musculoskeletal, bone density loss, osteoporosis. The symptoms may begin up to 6 years before the final menstrual period and continue for a variable number of years after the final menstrual period. And then as the postmenopause years progress with an accompanying loss of ovarian response to gonadotropins, associated affective symptoms of menopause will eventually decline. In other words, as the response continues to, ovarian response to the follicle-stimulating hormone and luteinizing hormone reduces, eventually, the symptoms of menopause will decline. On examination, the effects of gonadal hormone depression may be noted in the pelvic examination. The vaginal epithelium becomes red as the epithelial layer thins and the small capillaries below the surface become more visible. And as the vaginal epithelium atrophies, the surface becomes pale because of a reduced number of capillaries. Rugation around the genitals diminishes and the vaginal wall will become smooth. The menopausal ovary diminishes in size, and it's no longer palpable during gynecologic examination. You can't palpate the ovary again. Uterus becomes smaller. Fibroids become less symptomatic and shrink to the point where they can no longer be palpated on manual pelvic examination. And in older women, there's also a general loss of pelvic muscle tone, which is manifested as a prolapse of reproductive or urinary tract organs sometimes. Urogenital effects of diminished hormone levels are as follows. There's a decrease in urine pH leading to a change in bacterial flora, which may result in pruritus and a malodorous discharge. There may be insertional dyspareunia or pain in the vagina. Endometriosis and adenomyosis are alleviated. Atrophic cystitis, when present, can mimic a urinary tract infection. Now, diagnosis of menopause is largely clinical. There's no particular quick level test that can point out and say, yes, this is it. A quick questionnaire that can be used in the primary care setting is the MQ6, which is recommended heavily by the Canadian Society of Obstetricians and Gynecologists. And there are 6 quick questions. We're now going to the questions. Now, this is the menopause quick 6 questionnaire, and the questions are as follows. We'll follow the arrow. Are there any changes in your periods? Are you having any hot flashes? Any vaginal dryness or pain or sexual concerns? Any bladder issues or incontinence? How is your sleep? And finally, how is your mood? And if a patient answers yes to any of the questions 1 to 4, she may be a candidate for treatment, and further exploration and assessment is warranted. So changes in your period, as you can see, menstrual irregularities signal imminent menopause, and it can be expected to last longer, median 11.8 years. Are you having any hot flashes? Up to 80% of menopausal women experience vasomotor syndromes. That's very important. Any vaginal dryness or pain or any sexual concerns, bladder issues or incontinence due to vulvovaginal atrophy, and which is the genitourinary syndrome of menopause, which reflects the changes to the vulva, vagina, and urinary tract and to sexual functioning owing to the menopausal drop in estrogen. How is your sleep? A common issue during menopause. And how is your mood? And then, as we do the questioning, let's not forget the family medicine tools. We'll start with the 5 protocol. We ask the patient about her feelings related to the illness, especially the fears. I, the ideas and explanations of the cause. F, functioning, the impact of menopause on her daily life. Does it impact her daily life? For example, we have already mentioned that one of the symptoms is sleep issues. Does the sleep affect her life and her ability to work and do her daily activities? Mood, does the mood affect her relationship with her family, at her workplace, at her place of worship, etc.? E, expectations of the doctor. What does the patient expect of us? The patient comes with several symptoms. She understands that she has menopause, but she wants information as to what are we going to do about the disease. That's where E, expectations, come in. It's very important that we find out the patient's expectations of the illness, what she wants done, what she expects, and how we can meet that expectation. Other family medicine tools that can be used briefly and quickly. Genogram. The genogram helps gain a picture of the potential severity and extent of symptoms in the patient by examining possible symptoms in family members, looking at inheritance patterns. We have already mentioned that some women, that the family history of menopausal patients may indicate that women in the family might have had the symptoms earlier in life, in the premenopausal. B, might have had very severe symptoms. So once we have an idea of the kind of symptoms from the family history through the genogram, we'll be able to help our patients know what to expect and thus map out how as resources from religion, economic, educational, and medical, family lifeline, significant events in the patient's life versus changes brought about by the menopause, family life cycle. The menopausal period affects the launching family stage, retirement stage, and old age stage. Family cycle, how family dynamics are affected by the menopause. Laboratory markers of menopause, they are not really that important, but in case you have to do them, or in case the patient has the money to do them, they can include the following: an increase in serum follicle stimulating hormone and endocrine changes that occur during the transition to menopause, with fasting follicle stimulating hormone being higher than the luteinizing hormone. The follicle stimulating hormone precedes the luteinizing hormone rise. FSH being the diagnostic marker for ovarian failure, luteinizing hormone not necessary. The large cyclical variation of estradiol and estrone observed during the menstrual years ceases. Fluctuation in levels is small and inconsequential, with the mean value being considerably lower. There has been speculation that thyroid function may change during the menopause. However, no specific changes have been observed or found. Menopause treatment. What's our aim of treatment? To relieve symptoms, to prevent bone loss, and to improve quality of life. Treatment may include lifestyle modification, complementary and alternative medicine, hormone therapy, neuroactive drugs. Sorry, I apologize for any internet connection problems. I'm getting notifications that my internet connection is a bit unstable. I do apologize. Lifestyle modifications. For hot flushes, the following may help: avoiding triggers like spicy food, bright lights, comforters, predictable emotional reactions, cooling the environment, such as lowering the thermostat using fans or air conditioning. Wearing clothing in layers that can remove as needed may help. Also, exercise and weight loss, very, very, very important. In fact, many of the papers I read really put a lot of emphasis on exercise and weight loss. Over-the-counter vaginal lubricants and moisturizers may help relieve vaginal dryness. Regular sexual intercourse or other vaginal stimulation may help preserve vaginal function for as long as possible. Complementary medicine, black cohosh or Actea racemosa, which is common in Northern America. Other herbal preparations and over-the-counter products do not appear helpful. Some studies say they may help, some say they may not. Soy protein, but a general study that I consulted, a review of literature that I consulted, said that it may not help. Soy protein has been studied with mixed results, but one soy product has been reported to relieve hot flushes. Use of regular exercise relaxation techniques to reduce hot flushes have had mixed results, although exercise, yoga, and relaxation techniques may improve sleep. Acupuncture also has some mixed results. For neuroactive drugs, in well-designed randomized controlled trials, selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors and gabapentin have been shown to be moderately effective in reducing hot flushes. A low dose of paroxetine is the only approved non-hormone therapy used specifically for hot flushes, but these drugs are less effective than hormone therapy. We're leading up to somewhere. Osteoporosis, very important. It's that I thought it might require a slide or two on its own. Bone loss accelerates in the late menopausal transition and continues for the first few years after menopause. Of course, there would be some bone loss as they are aging, but in menopause, there's a bit of acceleration. So post-menopausal women and elderly women should be treated early and on a long-term basis for osteoporosis, unless a contraindication to such treatment exists. So to prevent fractures among post-menopausal women with osteoporosis, these are the following drugs such as biphosphonates, calcium, vitamin D, calcitonin, hormonal medications, and estrogen therapy. More on the hormones later. This is a flow chart indicating how to evaluate a patient for osteoporosis. It indicates that you focus on patients that have risk factors for the osteoporosis. And it also indicates how you follow them up and how you treat them. Last but not the least is hormone therapy, which is very important and which is the treatment of final results. It involves the administration of synthetic estrogen and progesterone to replace a woman's depleting hormone levels and thus alleviate menopausal symptoms. The following are common clinical indications for prescribing hormone therapy: to relieve vasomotor symptoms, to improve urogenital symptoms, and to prevent osteoporosis. Once again, to relieve vasomotor symptoms, improve urogenital symptoms, prevent osteoporosis. So these are the following recommendations for patients who are greater than 60 years or more than 10 years since onset of menopause. It can be continued at an appropriate dose for an appropriate time. For newer users of menopausal hormone therapy due to inadequate, for whom it is indicated, transdermal oestradiol and vaginal progesterone is preferred. If there are other risk factors, vaginal treatment with oestradiol or estriol is preferred. Patients who have obesity, progesterone or progestrogens are a priority. Transdermal oestradiol should also be considered on an individual basis. And then lifestyle improvements are very important. In cases of patients with insulin resistance, estradiol is very useful. Menopausal hormone therapy should be recommended to men with type 2 family diabetes as it reduces progression and delays the appearance of long-term symptoms. In hypertension, menopausal hormone therapy can improve hypertension. Smoking, women should be counseled to quit. And exercise should help. And vaginal hormonal therapy will be very useful, but the woman must stop smoking. Dyslipidemia, transdermal menopausal hormone therapy is referred. Patients with venous thromboembolism, vaginal hormonal therapy with estradiol or estriol or progesterone is preferred. Contraindications to hormonal replacement therapy include a history of breast cancer, endometrial cancer, porphyria, severe active liver disease, hypertriglyceridemia, thromboembolic disorders, undiagnosed vaginal bleeding, endometriosis, and fibroids. Adverse effects: nausea, bloating, mood swings, breakthrough bleeding, breast tenderness. Risks: risk of breast and endometrial cancer increased, thromboembolism, biliary pathology. Of course, the modes of administration, we mentioned them before, but it can be local, creams, pessaries, rings, systemic therapy, oral drugs, transdermal patches, and gels, implants. And constituents of the drugs include estrogen alone, maybe combined estrogen and progestogen, selective estrogen receptor modulator, and then gonadometics such as tibolone, which contain estrogen, progestogen, and an androgen. I should mention that for hormone replacement therapy, it may be important to refer to a gynecologist first for expert care. Most of these things I'm mentioning on HRT are for information purposes only. So in evaluating a patient for hormone replacement therapy, ask questions about her age, menstruation status, menopausal symptoms, past and current history, family history, lifestyle factors, concurrent medications. Examinations and investigations to perform: body weights, waist circumference, blood pressure, blood tests, imaging, mammography, and then bone densitometry if patient is at risk for osteoporosis. These are the treatment options for hormone replacement therapy in various patients. And then also counseling points. Each of the products has various side effects. Estrogen containing, and it's very important, as you can see, that patients must be counseled at every step of the way regarding the problems and the side effects with whatsoever combination that they use. Finally, this is the evidence-based algorithm for management of menopausal symptoms in patients based on the menopause quick 6 response. As you can see, we have the questions here. If symptoms are noted, we then look for contraindications such as vaginal bleeding, breast cancer, liver disease, thromboembolism, CVD, CVS, pregnancy. If it's not indicated, we then go to non-hormonal management of syndromes, where we can use gabapentin or pregabalin for vasomotor symptoms, SSRI or SNRI, clonidine or congenital or cognitive behavioral therapy or hypnosis for vasomotor symptoms. Sleep, you can see that the sleep problems can be managed by either gabapentin or SSRI, SNRI, and mood can be managed by drugs as well too. Serotonin, selective serotonin reuptake inhibitors. If there are no comorbidities, if the patients, as you can see, if the answer to the question is whether there are no contraindications, we then look for comorbidities such as diabetes mellitus, hypertension, smoking, obesity, high lipid levels, and gallstones. And then we modify our treatment, as such. If there are no comorbidities, we then use estrogen. If there are comorbidities, then we use titrated estrogen preferred. And as you can see, if there's any hysterectomy, we then modify our treatments as such. And as you can see, the recommendations as well are there. What's the role of the family physician? The family physician can be a caregiver. He can offer ongoing care to the premenopausal and menopausal woman, as well as note the changes that occur as a result of the illness. Communicator, offer information about menopause, especially its cause and treatment. Researcher, effects of menopause on family functioning concomitant illnesses. Advocate, for better community and government support for initiatives designed to help improve the health of the menopausal woman. So menopause can be managed effectively by various methods with the sole aim of relieving symptoms effectively and improving quality of life. It is a part of a woman's life, but it needn't be a bad part of it. These are my references. Thank you.
Wow, Dr. Thomas, what a very wonderful presentation. Oh.
Very nice, very good presentation. Very, very good presentation.
Thank you, sir.
Nice presentation.
Thank you, Chief. Thank you.
Yeah, just at that Nigerian age now. Wow.
That's what I was able to get from.
Let's go back to that slide. That Nigerian age, those ages.
Slide 7.
Slide, oh, you even remember the slide. Dr. T, let's go to slide 7, please.
Okay, just a minute. Okay, not the. Okay, no, it's not that.
Okay, okay, no, sorry, it wasn't that one. Epidemiology. I can't remember the slide number.
Okay. Yeah, that's it.
In Nigeria, 45 to 52.
That's it.
Okay. I don't know why he's laughing. That's what I'm not here for.
So people are worried about you.
I did come across it on one paper.
Lulu, are you worried?
Very nice presentation. So interesting.
Thank you.
Very beautiful presentation.
And then anecdotally speaking,
that age is not off, really, Chief Lucy.
Eh? You say?
Hello?
Yes.
That age.
Yes.
Well,
that
anecdotally speaking,
it's more pre-menopausal Nigerian women. Can you hear me?
It's menopause.
He said it's menopausal.
It's menopause, yeah.
Early menopause.
Far-fetched. It's more common. You see more premenopausal symptoms around that age.
Yes.
The women start having that symptoms, but they are not full-blown menopause at that age.
Yes, that's it.
It's really
they
not
still
common.
seeing their periods. Yes.
Okay. So we should relax, eh?
We have to do some more research in Nigeria.
It's true.
Yes.
Okay. Shog is laughing at me.
I think I'll
Dr. Thomas, see the question Dr. Taiwo asked you.
Yeah.
What is menopausal belly?
Belly. It's menopausal belly.
Okay, just a minute. Menopausal. Sorry, I'm coming. 1 minute.
Belly.
Then the registrars, you can see that
Menopausal belly.
Belly, yeah.
Sorry, I'm not sure I know that. I'm not sure I came across that.
Okay.
Yeah, someone that said Google should answer it now, the residents.
I'm not sure about I know about that, unfortunately. Sorry about that. I didn't come across that.
The pathophysiology in menopause is they lose estrogen, Abby.
Yes.
The reduction in estrogen. So it leads to fat distribution in the abdomen. Yeah, that's you see a lot of menopausal women, they have truncal obesity. A lot of them have it. It's as a result of the loss of estrogen, inability to burn fat easily, and the fat now accumulates in the abdominal region. That's just what it is.
Okay.
Okay. Menopausal belly. Oh, can you tell that I'm hitting my tummy?
Chief Lucy, we are waiting for you. We are waiting for you.
I'm coming.
We are waiting for you.
So, can I interrupt before Zoe starts calling for my attention? Hello.
Yeah.
Everybody.
Good evening, Chief Mimi.
Good evening. Good evening.
What's up?
Welcome.
Okay, so Dr. Thomas, I think you really did a wonderful job with your presentation, and I think every other should learn from that, because I had questions already coming in, and every other slide that came answered those questions. And I haven't any.
Thank you very much.
Very good. So please, the younger residents, please learn from that, because this is what distinguishes you as being a family physician, where you can inculcate the tools as well as the role of the family physician. So that is what you should be focusing on in your presentation. Also, for case write-up, a thought was going across my mind, because we have patients, they really don't come in as menopause, as in menopause. Doctor, I'm having menopause. No. They come in with various, they come in with various symptoms. I think I have diagnosed 2 or 3 people. The final diagnosis is actually menopause, and it also means that we should have a keen eye for that, especially in that age. Okay, so for case writing, I don't know whether you're working on waters, but I think it will really be nice if we have a straightforward, if anybody is interested in writing a case on menopause, a straightforward menopausal case. If you can, somebody comes in and says she's having insomnia, we understand she's this age, you use your family to diagnose eventually that she's having menopause. You see your health education comes in there. You are a coordinator, you are able to link her up, you're able to have family counseling, you're able to, because the men will not understand what the wife is going on, and they think the wife is having some psycho issues. Okay, so I think if anybody wants to write a case up, it actually is for a straightforward menopause case. I think you would do well in writing exactly following Dr. Thomas's slide. Okay. So once again, Dr. Thomas, thank you. Well done. And I hope somebody will present andropause. He may be a woman this time, so that, because he really dealt with the menopausal thing. Well done. Thank you so much. All right.
Okay. Thank you very much.
Thank you, Chief. We appreciate that so much.
I think Chief Otokpa is raising her hand. I think so.
Yes. Good evening, everybody.
Yeah,
good evening, Chief.
It was a good presentation. Actually, I was interested because I remember my part 2 West Africa was actually menopause and depression. And we got the age of menopause. Well, my study was a small study, but I think most of the women were from 51 years old and above. The average age was between 51 to 62. The average was 55 point thereabouts. It was not the main of the study. The aim was not really to get the age of menopause. It was looking at depression, menopause, post-menopause. And then another thing he actually explained a lot of things about menopause, and it was interesting. Another thing I wanted to point out was that menopause is not really an illness. It's a stage of a woman's life.
Yes, it's true.
A lot of us are moving towards that area. So let's not see it as an illness. That's another thing. Yeah. Then also I found out that what got my interest was that most of the highest symptoms that most people had, my study was in Lokoja anyway, that they complained of was hot flushes. And it was affecting their quality of life. And I discovered that just simple health education, you said the role of a family physician and educator the moment you explain to them that it's not a spiritual attack, because they are feeling hot, but nobody can feel the heat, but they are feeling it inside. And the moment I could explain it and tell them that this is part of menopause, a lot of them felt so much better. And I encouraged them to speak amongst themselves, and all of them were complaining of similar things. So it was no longer, because at that stage for women, their children are grown, so that's the time they feel that a lot of spiritual attacks are coming and all those kind of things. So when you actually educate them on menopause, one of my recommendations was that women should be educated in OPD, women in the perimenopause, about menopausal symptoms, especially hot flushes, that it actually helps them to be able to cope better. And I think lastly, gabapentin, well, I'm doing like a small scale study. I've not really done a large scale, but most of the women I actually recommend gabapentin for, most of them come back with very good stories of how it helps with their hot flushes and their sleep problems. So I think we should also consider giving it to some of our women that really complain of hot flushes in our OPD. I think that's all. Thank you.
Right. Thank you very much, Chief.
Thank you, Chief.
Thank you, ma'am.
Welcome.
Okay, Akins. Are you there? All right. Do we have any more questions for Dr. T?
Registrars, contributions.
Yeah.
Sorry, I have a question to ask. What's the role of this what they call that? Something rose. Is it
primrose oil? Primrose oil.
Evening primrose.
Evening primrose.
Yes. Well, some women actually say that in some studies it's not really. Hello?
No, carry on, ma. Carry on, ma.
Okay, I was trying to say that it's neither here nor there. In some small studies, 1 or 2 small studies, some women claim relief from it. Some other studies, they say it's not really the primrose. So it's neither here nor there. But 1 or 2 small population of women claim to feel a little bit better with it, especially if their symptoms are related to some women come with breast issues, breast heaviness, and all that.
Okay. Yeah, thank you, Chief.
Thank you, ma.
Thank you, ma.
All right.
Hello, Dr. T.
Yeah, good evening.
Dr. Thomas.
Yes, good evening. Sorry, I can hear you.
Thank you, Chief.
Hello.
I think he's having network issues too.
Okay, it must be a network issue. Sorry,
Yeah,
I can hear you.
network challenges.
Sorry, my network too is a bit problematic.
Even his own network.
Come on. You mentioned something about about family genogram. I'm just throwing it out to all the registrars. Please. Hello.
Yeah, we can hear you.
Yeah, we can hear you.
Can you hear me
Yes, sir. We can hear you. We're here, sir.
We can hear you.
Yeah, I'm standing on top of the roof now. Hello?
Yeah, we can hear you, sir.
Go on, Chief Taiwo.
It's network.
Trying to say registrars.
But you will come back.
I think he's just trying to place some emphasis on genogram and the family medicine tools. So the registrar should really
registrar, though. Part 2, your family case, you must draw fine genogram and use the symbols and all those things.
Okay, I think he's still having network challenges, so I think we've lost his connection there. Anyway, I don't know if we have any more contributions, questions, comments. So I think we can round up. So Dr. Thomas, wonderful presentation.
Thank you very much, Steve.
Well done.
Yeah. So in the absence of any other thing, I think we can end the presentation for today.
Hello.
Oh, okay, he's
Hello,
back.
we can hear you, Chief.
Okay, we can hear you.
Yeah, I said it's important for the registrars to to know how to construct a family genogram. Dr. Thomas mentioned it. So I think they should just go ahead and look for materials on how you can construct a family genogram. It was a question in my part 1 logbook. Did you do, they said, tell us how you construct a family genogram. The man gave me a paper and a pencil and said I should draw one, that I just make up one. So you need to know what it involves. You know, how many generations will you trace, what is supposed to be there, and some of them have symbols as well. So it's probably like a homework for everybody to go and look it up so that we can discuss it in future.
All right. Thank you.
All right. Thank you, Chief.
All right. Thank you very much, everyone. Let's all have a good evening and good night.
Thank you.
Thank you.